Morning, everybody. We will be speaking about how to set up an operation theatre, and that would be our instruction course. All the speakers out here have quite a lot of experience in organizing an operation theatre, either in the designing process or running of it. And it'll be a pleasure to get questions from all of you afterwards if you have any. Since there's a paucity of time, I would now request Dr. Supriya to come over. She started her own eye center a few years back near Durgapur, and subsequently now she's working in Disha Eye Hospital. She's LVP trained. Thank you.
Thank you, sir. Good morning, everyone. There are many different ways of building an OT complex, but the essential principles that should be followed while planning the physical layout are exclusion of contamination with proper traffic patterns and separation of clean from contaminated areas. So the first and foremost thing to consider is the type of construction. Are we going to construct a new building altogether, or are we going to renovate an already existing structure? Is it going to be an exclusively eye hospital or part of a multi-speciality hospital? The next thing to consider is regarding the size of the practice, as this is directly correlated with the number of OTs required and thus with the requirement of the space. Designing an OR is not merely a simple civil engineering work, but it requires a combo effort of all the departments. So make a core design team comprising of senior nurses, electricians, plumbers, administrators, builders, and of course the surgeon, and try to visit as many theatres as possible in your locality to understand what works and what does not, and also to gain from their experience. OR has to be located on the upper levels and in the inner part of the facility to limit dust exposure. Regarding the finances, always set aside a budget and decide its upper and lower limit. Planning has to be done depending on the availability of the funds and space. Decide in the initial phase only if you are planning to offer general anesthesia, as extra space is needed to keep the anesthesia machine, and additional design is needed for requisite socket placement, suction and oxygen outlet system. Use materials which are locally available, durable, easy to maintain and resistant to microorganisms. An OT complex comprises of an operation theatre, scrub area, sterilization room, storage room, patient preparation room, changing room, and anesthesia recovery room. All these areas are divided into different zones. So what are zones? Zones are areas of varying degrees of sterilization in which bacteriological count decreases from outer to inner zones. Now, the OT complex is basically divided into 4 zones: protective zone, clean zone, aseptic zone, and disposal zone. The protective zone comprises of changing rooms for surgeons and staff, storage area, and transfer base. The clean zone comprises of sterilization area and induction area. Aseptic zone comprises of theatre and the scrub area. Disposal zone comprises of disposal areas from each OT and dirty corridor. So this is how zoning is done, by creating barriers and different levels. It is not mandatory to use stainless steel barriers, and it can be easily done by just employing aluminium panels. And there is no hard and fast rule as to the division of space among different zones. It can be done based on the availability of the space. Better to have separate entry and exit points, one for the patients and other for the doctors and staff. Clean areas should not have any toilets. Toilets should always be before entry to the changing room. OT should preferably be square in shape and should have an area of at least 6 to 6.5 meters square. 3.5 meters of height is sufficient for normal OT, but it should be more than 4.25 meters for convenience of fitting of laminar plenum and HVAC ducting. Doors should be at least 1.2 to 1.5 meters wide for easy patient movement. Doors should be of PUF sandwiched with stainless steel or HPL panels. Ideally, doors should be fitted with vision panels to avoid unnecessary disturbance and staff movement. We can have either sliding type of doors or swinging type of doors, but it is always preferred preferable to have sliding doors as it saves space and it prevents air turbulence. Ideally, doors should be electrically operated, hermetically sealed to ensure asepsis. Now, walls should be smooth, non-porous, non-reflective, and easy to clean. In modular OTs, walls are made up of stainless steel or EGP panels. To make that, initially a framework is laid down, which comprises either of brick wall or steel itself. And upon that, on either side, stainless steel or EGP panels are placed, which are then coated with antibacterial paint. The paint should preferably be white in color. Tiles can also be used instead of stainless steel in case of financial constraint. The grouting in the tiles can become dirty and harbor bacteria and fungus. Therefore, care has to be taken to clean the tiles and grout regularly, and if there is any gap, it must be sealed and waterproofed immediately. Floor should be slip resistant, smooth, shiny, and impervious with minimum joints. Flooring should be either inset mosaic with copper strips to carry away any static electricity produced, or it can be made anti-static by using PVC roll or epoxy. Ceramic tiles can be used if there is a cost issue. The false ceiling in modular OT is made up of stainless steel backed with calcium or gypsum boards. But in cases of general OTs, either metallic boards or calcium silicate or gypsum boards can be used, which are again coated with antibacterial paint, and it should be once again white in color. The height of the false ceiling should be at least 3 meters from finished floor level. The corners of the room should be coved to prevent dust accumulation. Scrub area should be located immediately outside each theater. The flooring in this area should essentially be non-slippery, and taps should be either foot pedal operated or elbow operated or infrared sensor operated. The most careful CSSTs are divided into 3 areas: zone of decontamination, sterilization zone, and sterile storage area. In zone of decontamination, primary cleaning of instruments is done. This area should have a negative air pressure so that air does not rush out into other spaces when the doors are open. An easy way to achieve this is by use of a powerful exhaust fan. In sterilization zone, final packing and autoclaving of instruments is done. This zone should have positive air pressure. Now, sterile storage area lies adjacent to the zone of sterilization, and this is used to store the sterile packs and articles. A temperature of 18 to 22 degrees with a humidity of 40% to 50% should be maintained in CSST, and there must be at least 10 to 12 air exchanges in an hour. There must be a provision for storeroom for storing intraocular lenses, less frequently used instruments, spare instruments, scrub dresses, and spare gowns. Ideally, the walls of the storeroom the cupboards should be made inside the wall with stainless steel, and shelves are made up of glass. But if this arrangement is not feasible, then cupboards can also be made from slatted metal or terrazzo. The cupboard should start about 30 centimeters from ceiling and finish about 20 centimeters from the floor to avoid dust falling from ceiling and floor landing onto the items. Good lighting is needed in OT. Light should always be flush to the ceiling. The position of operating table has to be decided before placing the sockets so that the equipment can be plugged onto the wall and can also reach the operating table simultaneously. Make sure there are no loose cables lying on the floor to avoid tripping. Always use double sockets with proper earthing fuse box. Keep a provision of generator and UPS in case of power failure. The oxygen and nitrous oxide cylinders must be placed in a separate room with easy access, and fire extinguishers should be placed strategically. Avoid using extension cables inside the OT. Clean filtered water is required for cleaning instruments and for scrubbing, while ordinary tap water can be used for cleaning OR. A separate overhead tank should be provided for OT, which must be cleaned periodically. Now, coming on to the most important aspect of any OT complex, that is air ventilation system. The main purpose of air ventilation system is to control the temperature, pressure, and humidity, and also to dilute airborne bacterial contamination. The current trend is to employ heating, ventilation, and air conditioning system. Now, this HVAC system has an outer air handling unit and an inner laminar airflow plenum. The AHU of HVAC has 3 chambers. The first chamber has provision for entry of return air and fresh air inlet. Air in this chamber is mixed and then passes through a set of 5 microns filter into the second chamber. In the second chamber, the air is cooled, compressed, and then blown at a desired pressure, and then passes through a set of 3 microns filter into the third chamber. From the third chamber, air passes into the airflow plenum via 0.3 microns filter. As per CDC and NABH, a temperature of 21 degrees centigrade and a humidity of 20% to 60% and a positive pressure of 2.5 pascals must be maintained inside the theater. There must be at least 20 air exchanges in an hour, out of which 4 must be fresh air exchanges. The unique thing about AHU of HVAC is that it is both an air purification and air filtration unit, and there is a provision for fresh air entry, which is not feasible in window ACs and split ACs, as these are purely recirculating units and they have convenient pockets of microbial growth which cannot be sealed. So if there is a financial constraint, do not compromise on air ventilation system. It's better to cut down on other things. To summarize, designing an OT complex seems to be a tough task, but it can be made easy by proper planning and by utilizing resources in a channeled way. Thank you. Have a happy and safe surgery.
Thank you, Dr. Shupriya. I think we can take the questions at the end. Now I would request Dr. Shugato to come and talk on OT sterilization. He's an expert who's been working in various places, including England and UK, and now a leading consultant in Calcutta.
Good morning, and thank you. So thanks, Anshuman, for including me in this IC. I'll be speaking on OT sterilization and maintenance. So why do we need a clean OT? It has been seen that sterile environment reduces the surgical site infection, and surgical site infection are the second most commonest cause of hospital-acquired or nosocomial infection. And it causes considerable morbidity and can lead to high mortality. The sources of SSI can be endogenous or exogenous. Now, exogenous sources are from surgical personnel, from the operating room environment, and can be also from the tools and instruments which are being used in the operating field. So if you see, the operating room environment is a factor, and if we can maintain the sterile environment in the operation theater, we can control major part of the exogenous infection. So what is more important? Is it cleaning or disinfection and sterilization? Actually, both have their importance. Cleaning removes the contaminants, dust, and the organic matters, whereas disinfection reduces the number of the microbes. Now, disinfection of the OT is done with 3 levels of disinfection: high, intermediate, and low. High level kills the organism, accepts the spores and prions, and it is affected as sterilants, which has glutaraldehyde-based or orthoptaldehyde-based agents which are available in India. And there is intermediate and low-level disinfection as well. So OT cleaning and disinfection can be of 2 types. When you are having a new OT, setting up a new OT, and in a running OT as well. So in a new OT, you have to, it's a very rigorous step. You have to first ensure all the civil work has been completed. All the civil work has been completed and ensure all the movable equipments have been shifted out and cleaned outside the OT. Then you have to wipe all the surfaces of the OT and all fixed equipments such as OT lamps with liberal amount of soap and water, and repeat the wiping until all the visible dusts are removed. And it should be dried. This mechanism of wiping actually is very important to remove the spores and improve the action of the disinfectants which are used subsequently. So the next step is using disinfectants, and it basically with the disinfectants all the surfaces are wiped again and it's allowed to dry completely. Then the equipments which were moved out and cleaned outside are moved inside the OT, and the wiping is repeated again, and then it's allowed to be dry. Once this is dry, we have to think of fogging the AC, fogging the OT if we are not using HVAC system. And then we have to take the swab after 1.5 hours, 1 to 2 hours of the fogging. Swabs has to be taken from OT table surface, OT lights, then the sterile instrument trolley, anesthetic machine, 2 walls, floor, and also from the air-conditioned lower. After the OT sampling done on the second day, you have to clean the OT. You have to close the OT for the next day till next day, and next day repeat the same procedure again and take swab again. And again on the third day, repeat the same procedure. This is for a new OT. Once you get the report back, you have to ensure all the samples are free of any growth, or there might be some spurs, skin, commensal growth. If there are any growth of pathogens, then you have to repeat the process of OT cleaning and fogging once more and take samples again. If the results are still not satisfactory, then you have to take help of infection control expert. So in running OT, what we do? We have to clean the roof, the floor, the walls. The roof, doesn't require regular cleaning. Actually, it requires cleaning when the remodeling is done, as I have described, or when good amount of dust is accumulated. On the other hand, the floor gets contaminated quickly, and they require cleaning quite often. And you should remember not to use a dry mop, because it can spread the aerosol, or not to use the broom. You should use wet cleaning techniques, and floors should be decontaminated with vacuum cleaners. The OT has to be cleaned on the first before the surgery starts, and it's basically irrespective whether there is be OT running on the day or not, and no one should enter before it's cleaned. Clean all the horizontal surfaces with white wiping with high-level disinfectant, and ensure all the waste collection boxes are in place. Then keep the OT closed for 10-15 minutes with the ventilation on, and then you are ready for the OT. In between the procedure also, ideally, there should be some cleaning process, especially during the COVID time, we were quite rigorous in that. So clean the operation table, the theater equipment with disinfectant solution like detergent, and in cases of spillage of blood or body fluid, decontaminate with chlorine solution. Always discard the waste in the prescribed plastic bags, and don't accumulate soil, gown, or biohazard waste in the operation theater. And damp mop the floor for a radius of 3 to 4 feet around the OT table in regular interval. And at the end of the day, also, there should be a rigorous cleaning, and at that time, ensure that the OT table is moved and the undersurface of the OT table is cleaned with high-level disinfectant like bacillocid. So the cleaning has to be done in a methodical way. It should be in one direction around the room. It should be from high to low surface, should be from clean to dirty area. So the cleaner area should be cleaned first, and from back to front or farthest away to the closest area. Now coming to the fumigation. In India, as you all know, there are extreme OT facilities ranging from rooms with fans, then window air conditioning, and there are more sophisticated laminar airflow system. As you all know, most district hospital, they do not have the air handling unit or HVAC unit as Supriya has described, and in this situation, the quality of the air cannot be guaranteed. Now, so we actually divide the OT disinfection in two categories. One, the OT with HVAC system, and the other in OT without HVAC system. For HVAC system, it helps in, as Dr. Singh has mentioned, to maintain the indoor air temperature and humidity, control the odor, remove the contaminated air, and minimize the risk of transmission of airborne microorganism. And airborne unit with AHU and HEPA filters and laminar airflow can further help in maintaining the asepsis and infection control. So fogging is not required when you have a OT with HVAC system, but in this situation, you have to ensure that the ventilation system design is appropriate and the system performance is validated during the installation and at least once a year. All parameters in every validation testing should be within the permissible limit. You have to ensure that. And Maintenance of the ventilation system and the air handling unit should be done once in a year, and HEPA filters should be changed at time intervals recommended by the manufacturer or based on the results of the validation test. Weekly air counting should be done with settle plates or air samplers, and results should be within the acceptable limits. And because you are not fogging the OT with the HVAC system, cleaning of the OT is of utmost importance, and you should ensure that all the staff are aware how to clean, and there should be a protocol as I have described earlier. Now coming to fogging and fumigation. We all know the origin of fogging is traced back to 19th century when Joseph Lister aerosolized the carbolic acid to improve the antiseptic in the operation theater. It is done with formaldehyde vapor which is produced on low temperature and heating. And the mechanism is to alkalize the amino acid and sulfhydryl group of proteins and purine bases. It is widely used, but you all should know that it is hazardous and carcinogenic, but is being used because it's cheap. What we do here is basically there are two types. One is to use the electric boiler fumigation system, where for 1,000 cubic feet of OT, 500 ml of formalin is added to 1,000 ml of water in an electric boiler, and the boiler is switched on for 45 minutes to create the formaldehyde. And the second method is potassium permanganate method, where for 1,000 cubic feet of OT, 450 gram of potassium permanganate is added to 500 ml of formalin, and the room is sealed and left for 48 hours. Residual formaldehyde gas can be neutralized by using ammonia. Now as the awareness is increasing, we are moving away from fumigation to fogging in OT where there is no HVAC system. Here the formalin is being replaced with safer agents such as aldehyde-based product, glutaraldehyde, and the advantage is that they have not only they have deep penetration capacity, there is no known resistance strain, and they are effective against all sort of organisms. So here what we do is basically we use the fogger system, we prepare the solution according to the manufacturer's recommendations such as bacillocid, and we add 20 ml of bacillocid in 2 liters of distilled water and place the fogger in one corner of the OT with the nozzle directed at 45 degrees to the opposite side and start the fogger. We have to notice that whether the fog is there in the atmosphere of the OT through the OT window, and once the fog is seen, you can switch off the fogger and wait for half an hour to 1 hour. Now, once the fogging is done, you have to, you have to inspect for any wet patches after opening the OT. If there are any wet patches, you have to, don't wipe them, you have to let them dry naturally. And you have to also check whether the working surface has excessive stickiness. If there is excessive stickiness, then you have to check the dilution of the fogging material. And if it still persists, then you can reduce the fogging time by few minutes. Now, these are some commonly used disinfectants which are normally used in India and how they work. And we normally use bacillocid, which is formaldehyde-free, and it can be used in white wipe procedure. The process provides complete asepsis within 60 minutes, and formalin fumigation is not required when you are using this. The other one is EcoShield, which is also commonly used. It uses stabilized hydrogen peroxide solution on silver nitrate solution. Again, it has a widespread action, and this table actually shows how often we will clean the surfaces and what sort of solution is ideal and should be followed. Thank you very much for your patient hearing. So I think next speaker is our Chief Instructor, Anshuman. So Anshuman, please join in. Again, he has very good experience in OT setting up OTs. Please join in, Anshuman.
Thank you so much. Good morning, everybody. I've had the experience of setting up my own operation theater for Sankara Eye Hospital at Bahrampur. So I've had all kinds of variety, and all of us out here can actually make a good OT setup without much difficulty. It's just a matter of following certain principles and allowing certain protocols to be followed all the time, extremely sincerely and with 100% compliance. That is the most important thing when it comes to the OT. It's a place of worship. You should treat it like that. I'm sorry, but Dr. Shailja couldn't make it today because she had a problem with her family and some problems in her own health. So I would be speaking about patient preparation etiquette in her place. Subsequently, I'll continue with the next talk. So we all want the operation theater to be organized, not like this one on the left, but on the right side. So something that is not chaotic. Yeah, thank you very much. So we want all the OTs to be organized like this and not like this, definitely. So what are etiquettes? Basically, in principle, they are basically the set of rules that control accepted behavior in particular social group or situations. Putting it simply is that what all care you have to take, taking the circumstances and the social system that we have. So whatever is etiquette out here may not be applicable in America and vice versa. So you have to have your own set in our kind of setup, and if we have a rural or an urban setup, we have to make it accordingly. But following certain standard operating protocols that we govern and we make it. So why do we need these? Clear communication leads to enhanced efficiency. Enhanced efficiency leads to excellence and safety in patient care. Moreover, improved monitoring takes place during the surgery, and as a result, there's reduced chance of error. And all these things add up to make the OT running efficient and increase the cost effectiveness, putting your manpower and machine at the best place with least amount of utilization of finances and resources. So patient preparation etiquette involves various steps, as I would be going one by one: identification, documentation, preparation, transfer in, transfer out, and incident reporting. So identification is an extremely important step. The moment the patient walks into the hospital and goes in for an admission process, the first thing that should be done is identification tag should be put on the patient so that one knows that this is the patient who is planned for surgery. In that, it should be very clear his name or her name and the surname, the age, MR number or medical records number should definitely be allotted. If possible, it should also be clear at the onset only which eye we are operating. As we are all ophthalmologists, we should be on that. And there are different principles followed in different OTs and different admission systems, but generally what is done is a red band is put in the right hand and a blue in the left hand. But most important thing to understand is that you have to make a standard operating protocol, and everyone in the staff from A to Z should understand it, so that whenever you find that there is a place where there is likely to be an error, one or the other person can point it out without any fear or any loss of faith. So again, check for any allergies and also check out how the patient is behaving on the day of the OT. Is he hearing properly? Is he a very old man? Is he somebody who's frail, who's not able to understand? Or he's from another region and is not able to understand your language? Because most of us now are switching over to topical phaco, and even with giving an injection phaco, local anesthesia phaco, we need to talk to the patient many a times during the surgery. Informed consent should ideally be always given a day in advance so that the patient goes through it, sees all the pros and cons of surgery, all the complications involved, and sign it knowingly, and that's why it's called informed. But then on all practical reasons, it may not be possible. But the most important thing to understand is please get the consent signed before you take up the patient on the OT table. That is 100% yes. If you haven't done it, you are in big trouble. The other things that you need to check out is the investigations and whether they are under normal parameters. If a patient is there who's likely to have a raised blood sugar or something, you should do a blood sugar at the time of entry of the patient and recheck him. In case a patient is for general anesthesia or a child, then or a disabled patient or a mentally retarded patient, special care has to be taken. And those patients who are going in for anesthesia, general anesthesia, definitely a pre-anesthetic checkup is a compulsion. So the other part is that you see the gait of the patient once the patient walks into your OT complex, because you want to see if there is any other problem the patient might be having. Is he too drowsy? Is he having a gait which shows that he can't lie down properly, or he's got spondylosis? Because these are all going to affect the surgery ultimately. And there are cases where people have seen the patient is so anxious the night before that he hasn't slept, and he's so sleepy that while doing the topical surgery, they fall asleep and they lose the ability to remain straight. Other thing that needs to be seen is patient hygiene, whether he's clean or not in the facial area, at least with his eye surgery. If he isn't, then he can be asked to wash his face with soap and water. How is his otherwise sensorium? Is he claustrophobic by nature? Then one more thing that is often followed in most of the OTs is that we change the street clothes to OT clothes. But yes, some people in the process of modernization don't do that. But every hospital has its own rules, and I think one should have a standard protocol on that. The other thing, especially related to patients, lady patients who wear a lot of jewelry and all that, their jewelry should ideally be taken off at the time before the surgery. But in case they are not in a position to be taken off, because many times the screws are very tightly put, then in that case, cover it with a micropore. In the case of those people who have a hearing aid problem, if the surgery is on the same side, the hearing aid should be taken out, because many times fluid can go in and spoil the hearing aid. If it is on the contralateral side, then you can keep it because it helps in the communication. The same goes for ladies with buns. The buns should ideally be on two sides so that the big bun doesn't impinge on the head and disturb the patient. Again, dentures are absolutely a no-no. All old patients should be asked whether they have dentures or not, because it's a very big source of having a blockage of the airway while the patient is lying down. So again, coming back to basics, checking the hypertension of the patient, whether they have taken the medication in the morning, if they're a diabetic, if they have taken the medication, have they taken any food along with that, have they stopped their blood thinners, and so on and so forth. And the local examination is extremely important. Check both the eyes. Even if you have redness in the contralateral eye or a secretion, you should be very careful, because we can have a spread of infection from one eye to another. Then going back to the general checkup, again, BP, SpO2, blood sugar, all these are checked. Patient is put in OT clothes, cap and shoe masks are given, and IV line may be put depending upon the situation. Any allergies should have been noted preoperatively, and in case it hasn't, it's not a bad idea to recheck once more before you start dilating the patients. Some patients who are hypertensive, it will be better to use a drop without phenylephrine. And anesthetic drops, again, you have to use Paracaine, or depending on if you're doing a local anesthesia, injectable, you don't need to do that. One more principle that we most all follow is we apply povidone iodine 5% 5 minutes before the commencing the surgery to sterilize the area. Other than preparing the patient, the OT area should also be nicely prepared for the surgeon. For instance, that whatever you are implanting the IOL, maybe at least those IOLs and a backup IOL should be there. And if the case requires specific changes, like for instance, special viscoelastics, dilators, anything like that, they should be available as per the case requirement. Children, physically handicapped patients, of course, have to be taken with extra care. Those with HIV, you have to take extra care that you don't get infected by them and the staff doesn't get infected by them. If a patient, now this is one thing that a lot of people neglect, if a patient is for any reason cancelled or rescheduled, please do not neglect the patient. Explain to him why it has happened and when is his eye surgery going to take place later on. Because many times you just forget about him that, oh, the OT cancelled, let him be sitting there and tada bye-bye. So that should not be the type of attitude that we should have. Okay. Now, there are 3 processes which are followed more or less because of NBH now, and it is a very good process. Is basically we do what is known as sign-in, time-out, and sign-out. Sign-in is at the time before anesthesia. This is the time when all the staff, anesthetist, surgeon are around the patient. Each one of them is given a call, and a kind of attendance is taken that all are present in one place. And preparation for giving the injection, if you're giving a local anesthesia, takes place. incision, at the time of incision, just before starting, is known as the timeout. Again here, the nurse out there, she checks out whether all the surgeon anesthetists are around and everything is nicely prepared or not. And the last step is sign out. When the surgery is over, in case of other surgeries, you check for like gauges and all that, but in eye surgery, we don't do that. But we see that the pad bandaging is done properly, the eye is nicely closed. If you're doing topical, the patient closes his eyes properly without any difficulty, and a discharge note or a post-operative order is given at this stage. So sign in, as I said, in peribulbar block, you should have preferably a crash cart, which should take care of any adverse events during the injection process. And of course, you should take care that whatever drugs you are using are not expired. And before giving the block, of course, check the identity of the patient and the eye that is being planned for surgery. Because these are places where errors take place, and many times it happens that the block is given in the wrong eye and the surgeon also operates in the wrong eye because he sees the block in that eye. So this is a very big point of error which should be extremely carefully handled. So of course we have the standard method of draping, and I think all of you know how it's done, so I'll just skip through this more or less. But important thing to understand is if you have a situation where the patient has a breathing problem, it would be nice to have a tent over the face so that the tissue or cloth falls over the nose area. And finally, of course, the draping of the eye is done with a sterile drape, and incision is made very carefully. Again, out here, the incision should be made very carefully and taking care that you don't traumatize the eye or the lids, which have happened with certain surgeons, so you have to be extremely careful. So your staff or you, whoever is doing it, has to take extreme care that you don't cause any damage to the tissues underneath. There are certain standard charts which are available from WHO which tell you a kind of a checklist, what all you need to do before, at the sign-in, time-out, and sign-out. And this is available on the website of WHO, and you should be able to follow it. On the surgery table, very important to have a surgical safety checklist. The part of the checklist is made preoperatively in the OPD area where the surgeon writes down the eye to be operated, the type of cataract, how much is the hardness, what special care you have to take, is the pupil nicely dilating or not, do you need to have any other viscoelastic or a pupillary dilator for it, and any other factor like a deep set eye or something, or spondylosis or something problem where the patient cannot keep his head straight on the bed are noted down. And this checklist should be there beside the surgeon on the OT table, so that when he sees the patient, he has to first recognize the patient and check out what all is required. So again, in the transfer out portion, basically the patient is shifted out, checking that all is well, and the post-operative advice and discharge are given. Important thing is, last but not the least, is incidence reporting. This is an extremely important step that all of us should follow. It should be a no blame game system where you don't blame anybody if that person is blamed, has made a mistake, because they will not come out with their faults or what they might have made a mistake unless and until you have this policy. So just allow them to say if they have made a mistake and correct it, and do a root cause analysis later on and bring about changes in your protocol so that it doesn't get repeated. And this is the final slide on the process map they follow. Thank you so much. I hope I didn't take too much time. Thank you very much. I'll go on to my next topic. Any questions? We can have it at the end, I believe. You can just make a noting of it. Okay, so ready? Thank you. So this is another extremely important part of OT training, which we unfortunately never learn during our MS days. We are all peeping into the eye, looking into the eye, treating the eye, but when it comes to handling the OT or the instruments, we know nothing about it, unfortunately. So I have no financial interest in any of the products that I show here, But yes, I'm extremely thankful to all the staff and seniors who taught me in the process over the last 10, 15, 20 years how to handle the OT instruments, how to clean them. It's a learned process. You learn it from many people, including the ward boys and the OT technicians. There's nothing shameful about it. But you should all know. Even the person who's not doing any of this work should know, because unless and until you know it, you cannot correct others. So we learn, but don't learn how to clean and sterilize our instruments. So why do we really need to clean our instruments? You may just wonder, why not just straight away take the instruments, put it in the sterilizer, maybe a ETO or a steam sterilizer, and finish off with it. That doesn't happen like that, and I'll explain you why. There are 4 processes that are taking place: cleaning, packaging, sterilization, storage. Our esteemed speaker, Dr. Bhaskar, would be speaking about sterilization later on after this. So I would please like to skip around and go to the next slide. And that is, cleaning and rinsing are most important, because many a times we use substances like viscoelastics, the cortical matter which is present in the cataract, which may get stuck up in lumen instruments like the Simcoes or the IA cannula. There may be a lot of blood or fluids which are sticking onto the instrument, which can cause deterioration of the surface of the instruments and pitting during the sterilization process. And organic material and soil debris can block the sterilization agents from going in. So basically, during the autoclaving process, the tissue gets baked in and it goes over the surface of the instrument and doesn't allow the heat or the steam to penetrate and sterilize that area. So when you're about to do the surgery, if that particular baked area or the tissue that is stuck moves away, you're actually operating with the area which is not sterile or not adequately sterile. So, of course, we know all of this, toxic anterior segment syndrome. I hope many of us haven't faced it. And the most common cause for this is, of course, OVD, which has been left behind in the lumen. Of course, it can also be caused by metal precipitates, contaminated solutions, intraocular medications, and even intraocular medication or solutions which are not in the right pH or in the right concentration. So this is one of the major reasons why cleaning of instruments is essential. When does cleaning start? It starts the moment the surgery starts, because the cleaning process has to be an ongoing process. It has to be done while the surgery is taking place. You don't do it and leave it for the end. Your assistants have to be trained. The moment the instruments are kept back in the tray, they should be cleaned in saline or ringer lactate, whatever solution you have, so that whatever residual blood, or most importantly viscoelastic in our cases, is washed off from the tip and doesn't get stuck onto it, to be removed later. This also actually preserves the tips of the instruments for when you are cleaning it later on. One thing is to have a dedicated staff, maybe responsible, especially in a high volume OT. You should have a dedicated staff who continuously take away the instruments from the use set, take it to the cleaning area and start cleaning it immediately, so that whatever material that has got dried up gets cleaned up as early as possible, and the instrument life increases and the safety of the patient in the long run increases. Again, in the area where the cleaning takes place, the first step that the cleaner does is segregation. He takes the unsterile instruments, first disposes the disposable ones, takes care that the sharp blades and needles are destroyed properly, and then he selects the non-sharp reusable instruments which are to be used for the next case. Here, if you're using, you're doing a normal cataract surgery, you may just clean it with non-ionized solution. But if you are not, if you're doing some very infected surgery, for instance, a DCR surgery, it's extremely, a lot of organic material and bacteria may get stuck onto the instrument. So these should ideally be treated with enzymatic treatment for 24 hours before they are taken up for the next case. So there are a lot of solutions, and some of them Dr. Shugota has already mentioned, and I'm sure our esteemed speaker, Dr. Bhaskar, would be speaking later. I don't have any financial interest in it, but just a mention of a few which are relevant to the cleaning process. We can use a surfactant-based cleaning process like Blanazol Pure, which is basically a substance which helps in removing the dead tissue, blood, viscoelastics from the surface of the instrument without causing much problems later on. And in case of, as I said, DCR surgery, you might require enzymatic removal, that is, those substances which actually break down the proteins that are left behind in the instruments and do a thorough job of cleaning. The important thing to understand is whatever solution you use, it should be low foaming, easily rinsable or biodegradable, non-abrasive, and disperses organic soil, and it's non-toxic. Before we take the fine instruments into the other area, they can be cleaned with the help of non-ionic solution or even distilled water for a start, using a brush, a soft brush, which helps in not only cleaning the nicks and corners of the instrument, but also prevents the instruments from getting spoiled because of manhandling. Instruments which have joints, for instance scissors, forceps, they should ideally be nicely opened, their hinges cleaned properly. In case of where you have assembled the instrument, they should be totally dismantled before they are put to sterilization. Hollow instruments, again, you have to take extra care because there's a lot of material like lens matter and everything which is going into the tubing and may remain so if you don't clean it very properly. So the best way to clean it is use non-ionic water, clean it, flush it from one end thoroughly using about a 20 cc or a 40 cc syringe and cleaning it from one end to another and then flushing away finally the solution also, so that no residual solution is also left within the system, though it's non-ionic, but you should at least dry it before you take it up for the autoclave. And the same applies for some phaco machines which allow you to clean the instrument and the tubing by attaching the irrigation aspiration tubings and cleaning it with the process of, instead of using the ringer lactate, you use a non-ionic water on the other side. The important thing again out here is if you have a multiple surgery OT, it's best to change the tubing every 2 cases. One helpful thing to do for cleaning is having an ultrasonic cleaner. Ultrasonic cleaners are freely available. Basically, they help in agitating the instruments and the solution and helping the dirt material to come out of the instruments. So you can use a standard protocol where the ultrasonic machine is first primed and the solution for disinfection for surfactant is put in it. Then once you see that there is bubbling which indicates that the ultrasonic machine is working and the time factor for priming is over, the instruments are put inside, and these are instruments which have been priorly cleaned with water at least, that is at least distilled water. Once this is done, the instruments are taken out. They may again be washed with distilled water, though my experience has been that it's not really required, doesn't lead to any problem. And subsequently, the instruments are wiped dry. It's very important that they should be wiped dry because they are going to go into the steam sterilizer, and we don't want any fluid waste to remain anywhere. Of course, before packing, you should put one of the indicators, sterilization indicators like signal lock or any other indicators. Large instruments, they may not fit into the ultrasonic cleaner, so you can just do it in a bucket where you have large volume surgeries. They can be done in one go and wiped clean with a cloth. Coming to the packaging of instruments, the packaging of instruments can be in rigid containers, peel pouches, wrappers. But the most important thing to understand out here is whatever you're using should be compatible with the instrument in use and the standard sterilization method of that instrument. If you have a plastic substance and you're going to autoclave it, you're going to destroy it. Or a ETO substance which imbibes the ethylene oxide for too long, it's not a safe way. So you have to choose your way of sterilization as per the requirement and the manufacturer. So we have rigid containers where we can store the instruments before we put it for autoclaving or sterilization process. The important thing to understand out here is that you should have adequate space between the instruments in steam sterilization to allow the steam to go through. And a very important step which may be missed at this point is many times people forget to open up the vents before they are putting it in the autoclave machine, and they should be opened up before you put it and immediately close the moment the can comes out of the autoclaver. We have, of course, other pouches which are available, which can be used to put small instruments inside, and then they can be sealed with a heat sealer. And the advantage with these pouches is that there are pre-markers for ETO and for autoclaving and sterilization, which change colors, so you don't need to, it's a double safety method that you have. And finally, a small video on how wrapping is done, because this is again very important, that you should use a material which is porous to steam or to ETO, depending upon what type of sterilization you're going to use, and pack it in a way that it's also easily dismantleable at the time of operation theater work. So it should be double packed. There should be one packing inside and one packing outside, so that the nurse can open up the first pack and hand you over a packet which has another sterile packing over it. This way it ensures that you don't touch the instruments inside. Thank you very much. Any queries, you can take it up in the later part, maybe after the last talk. And in case you need any queries, my email ID and WhatsApp numbers are there. You can, of course, call me up. You can note it down from there. Thank you. But you had a single question. Maybe we can take that. Yes, it should be ideally done, but it depends, because not anymore, but you never know when you have to give a block to the patient. So it's best if you don't. This is a debatable topic. Please. Dr. Bhaskar, he'll be speaking. He's an expert in OT construction, making, designing, administration, and has been he's been able to organize about 4 or 5 types of OTs at different places. So he'll be speaking about the sterilization protocol. Thank you.
Thank you, Anshuman, for the kind words. It also means that I'm not an expert in operating, only in setting up operating theaters. So most of what I'll be talking comes from my experience and from the CDC protocol, which I will show you as a reference. So you already must be having a lot of questions, and we'll take them up at the end. And it's very, very heartening to see a full house on the last day of AIOS. So that itself underlines the importance of setting up a good OT. So there are many, many controversial areas, like whether blood thinners should be stopped, whether there should be one table in the OT or multiple tables, what indicators are you going to use, how often you are going to use. So I'll be trying to addressing those. But as a foundation to the answers of those questions, we must first understand some basic terminologies which have been touched upon by the previous speakers, like what is cleaning, what is disinfection, and what is sterilization. And I'm very happy that the previous speakers have underlined and stressed the need for cleaning, because cleaning is the physical removal of organic material or soil from objects and is a prerequisite for disinfection or sterilization. So while sterilization means removal of all all germs, microbes, including their spores, and disinfection is killing of the bacteria and fungi without the removal of their spores. So that is the difference. So when we are doing sterilization of the instruments, it is a sterilization and not a disinfection, because removal of spores are equally important. So we have already dealt with this, why cleaning is important, because it interferes with the penetration of the sterilant, whichever you are using, whether steam or chemical. And antiseptics are germicides which are applied to the live skin. So the betadine dressing and draping that you are doing, that dressing is actually an antiseptic. So it is removing, it is making your field free of microbes, whereas disinfectants are applied on inanimate objects. So OT cleaning will become a disinfection, cleaning of the surgical site will become an antisepsis. So they're grossly divided into 3, and we will be mostly using high-level disinfectants, mostly glutaraldehyde based, which are now on the way out, and some stabilized hydrogen peroxide and quaternary ammonium compounds, which are now in vogue. So chemically they are classified into all these. Out of these, the oxidizing agent H2O2, hydrogen peroxide, and quaternary ammonium compounds and glutaraldehyde, these are the most commonly used disinfectants for OT instruments. Likewise, instruments also have to be classified into critical instruments which enter secluded zones. The anterior chamber of the eye is a secluded zone because it is away from the bloodstream and from the natural defenses of the body. The non-critical, on the contrary, are those that come in contact with intact skin. So the sponge holding forceps which are using to clean the outside of the eye is a non-critical instrument, whereas the forceps that is going into the anterior chamber is a critical instrument. And we will be focusing mainly on critical instrument. And as one of my professors had taught me early, that don't ever touch the business end of the instrument. So whenever you are handling the instrument, it is important that you don't touch the tip of the forceps or you don't touch the tip of your iris spatula. It should be handle-to-handle transfer. Okay, so the rest of the talk will be on sterilization, storage, and monitoring. The most common sterilization techniques that we use are steam under pressure. So that is temperature and pressure, that is autoclave. And we have something called a flash autoclave, which actually gives us a lot of mental peace, but it is not really that great, as I will tell you. The most common chemical indicator that we use is ethylene oxide, and the newer, lower pressure, lower temperature, so less damaging to instruments, is the hydrogen peroxide-based plasma or the cold plasma technology, which is really not caught up in ophthalmology, although it is practiced in other industry to a large extent. And if you have a bucket list of what are the things that you should do in the OT and you should not do in the OT, like fumigation, cleaning of air, whether you need a HVAC system, etc., etc., the first thing that should come is a good quality autoclave, because that is cleaning, the disinfecting the instruments that are actually going into your operative field and the most likely to cause endophthalmitis. The second most important thing would be the OVDs and solutions that you are putting into the anterior chamber, because if they're not sourced from good quality pharma companies who maintain the sterile chain, that can also land you in trouble. Probably the least important would be the OT air, because I have seen many OTs where OT air is not maintained at all. Not to send a wrong message, it's not that it's not important, but in the whole list that you have to check when starting an OT, the autoclave should come in first. And we have steam sterilization goes through these cycle of cleaning, drying, inspection, packaging, sterilization, storage, usage, and then again cleaning. There are two basic types of steam sterilizer. One is the gravity dependent, which is the one that you have the vertical autoclaves, in which the steam is generated at the bottom and it rises as it is lighter than air, and it will replace all the air from within the cavity of the autoclave. Now the problem with this is that the lumen instruments, which are closed at both ends or half closed at both ends, like a phaco handpiece or a phaco tubing set, there the steam will not enter because it is gravity dependent. There is no active process working in it. Over there you need pre-vacuum, that is class B autoclaves. I will be talking about the classes of autoclaves. So pre-vacuum is very important in the ophthalmology setup because we do use lumen instrument. So removing that air from within where steam will be able to enter subsequently is very, very important. So a flash autoclave is not faster in the sense that the steam time is not less. It cannot be. The steam timing will be same as high-speed normal horizontal autoclaves. So these are the classes of autoclave. We are concerned only with the last. There is a class B autoclave, which is completely removes air. So there is a pre-vacuum cycle and a post-vacuum cycle in which the steam again is removed. So flash autoclave, one thing to be remembered is that it is for unwrapped instruments. If you are using a flash autoclave, you should not use wrapped instruments. That is for the normal class B high-speed autoclaves. So for packaging, Anshuman has already said, but it is very important to disassemble instruments that can be disassembled. So specifically, the phaco tip and sleeve should be opened and separated and autoclaved. They should not be autoclaved in situ. And heavy items should be placed lower because they tend to damage the more delicate instruments like your choppers and Sinskis. So that has to be maintained. These options are there. We can still use drums, although in many talks you will find that drums are deprecated. But especially those of you who are using vertical autoclaves, drums has to be used. It's easier to take them out. what is important is to have the pores of the drum open when you are putting it into the autoclave, and to close it immediately after removal from the autoclave cavity, so that outside air cannot enter. So this is the one point, that the pores are open when you are removing it from the autoclave cavity, that militates against use of drums, because the other two options, which is the plastic wrappers and the paper wrappers, particularly the blue ones that Anshuman showed, they are designed in a way that when heat happens to touch it, the pores open, they expand. And as soon as the autoclave cavity cools down, they contract. So it automatically gets sealed. So it is advisable to move on to such woven or unwoven wrappers, or even the plastic devices. But as Anshuman said, you have to be sure that it conforms to the recommendations of the manufacturer, otherwise the plastic may melt. So the packaging material must allow penetration of the sterilant, whether steam or ethylene oxide, and it must protect against contamination. So it should not be easily penetrable for mechanically the instrument to come out, and it should maintain the sterility of the processed item after sterilization. So double wrapping, as Anshuman showed the wrapping, it can be done sequentially or non-sequentially. Sequentially means you wrap it once, then you wrap it again in another cloth. Non-sequentially means you take two layers and you wrap it together. Okay. So wrapping should be done in such a way that there is no tenting or gapping of the thing, so that air cannot enter otherwise. So when you are loading the autoclave, it is very important to load it in such a way that the steam can percolate and enter through. So if you are stacking them very tightly, then the interfaces steam will not enter. So it is very important to stack them loosely. Now about storage. This is often the most ignored part. We have a feeling that once autoclave has been done, everything is fine, so it can be placed anywhere and it can be opened and used at the time of surgery. Now ideal places of storage should be far from the floor, ceiling or outside walls, and there should be adequate circulation and cleaning and compliance with the local fire norms. So sterile items that become wet, they are considered to be contaminated. So even if you have the outer pack intact and you have used a plastic wrapper or a cloth wrapper, if it is wet, it is contaminated, it has to be re-sterilized. So ideally it should be kept in closed or covered surfaces, but open shelving is also permissible. If it has fallen to the floor, there is a question that it just fell from my hand, so is it contaminated? Ideally in an OT setup, anything below the waist is considered to be contaminated. So even the undersurface of the table, and that is why you will see we advise our assistants not to hold the trolley railings. That's bad practice. So the rule of the thumb is anything below your waist is unsterile, and if it has fallen and you are picking it up and opening it, the chances are that the contaminant from the floor will stick to your hand and you will transmit it somewhere else. So it is best to re-sterilize if it has fallen to the floor. Do they have an expiry? 2 years, 3 years, 5 years? Review of the literature says that there is no concrete evidence to suggest that once an object has been sterilized in a properly wrapped and stored properly, is not wet or has not fallen, or the outer wrapping has not broken, then there is no upper limit to the sterilization, how long it will be sterile. And studies have shown that even up to 2 years, they maintain their sterility. But in common practice, we do not do that. For all autoclaved items, it is a maximum of 48 hours is the generally practiced norm. Although if you ask me for the source, there is no source, there is no reference. It is just what is practiced in the clinics. Hydrogen peroxide and cold plasma, unfortunately, has not caught up in ophthalmology circles, but it is one of the safest and most convenient and most eco-friendly methods of sterilization, because it does not increase the temperature locally, even to the level that ETO does. So your instruments and plastics are very well protected. Formalin is now discontinued for many reasons. It is toxic, irritant, mutagenic. Most importantly, It does not ensure a smooth, totally distributed concentration, and it is very difficult to monitor because indicators are not available. So if you are using a formalin chamber, it's time to get rid of it. You should now switch over to ethylene oxide. Now comes the most important part of monitoring of sterilization. So monitoring is a procedure that the purpose of which is to evaluate the sterilization condition and indirectly evaluate the microbiological status of processed item. Why indirectly evaluate? Because other than doing a culture from the instrument, there is no direct method of monitoring the level of sterilization that you have achieved. So it will, whatever monitoring technique you use, it will always be indirect. It is important to understand that. There is one is mechanical monitoring. It is as important. So you should take a look at the printouts or maintain a log. If you don't have a printout system with your autoclave, you should maintain a log when it was put into the autoclave, when it was taken out, how much maximum pressure was generated, and what was the temperature generated. So all those gauges have to be recorded, but most modern autoclaves have an automated printout system, and if the cycle is broken somewhere like by power outage, then the cycle is cancelled and you have to run it again. Mechanical monitors for ETO again are usually not required because most of the ETO machines now they come with a printout method. So we come to the most important point of evaluation of sterilization, that is indicators. So there are, broadly speaking, 6 classes of indicators, and it is important that we know the purpose of each. Class 1 is the signal lock cable, signal lock tape that you use. That is a process indicator. It just tells you whether the instrument has been put in the autoclave, has been exposed to temperature. So it is only a temperature, it's a temperature only indicator. And each signal lock strip should be dated. And I had the experience of a drum which was not put in the autoclave at all, and the OT technician thought that he will get a scolding, so he came and opened the completely unautoclaved drum. But incidentally, the OT sister, as per protocol, was vigilant, and she saw that that strip inside has not changed color, and he was caught immediately. So these things happen because, Anshuman was saying that we should not browbeat our staff because then they will try to hide facts. And the entire OT system is based on trust and trust and trust. So it is important to have process indicators, but the purpose of process indicator is only to tell you that whether it has gone into the autoclave. It does not tell you anything about the quality of sterilization. In many places, I have seen that the Bowie-Dick indicator, which is a class 2 indicator, is used as a surrogate for the class 5 or the steam and temperature indicator. That is wrong. Bowie-Dick only tells you whether the pre-vacuum cycle is working and it has actually attained a certain amount of vacuum. Class 3 and class 4 are not important for us. Class 5 is the most commonly used indicator that we use. So that is an integrating indicator which includes both temperature and pressure. And class 6 are emulating indicators, which I will elaborate now. So we will be focusing mainly on class 1 and class 5 and class 6. So this is the process indicator. It has to be put on every pack, and if you are using rigid containers, then it has to be put on the outside of the container as well. This is the most commonly used type of indicator, which is an integrating indicator. So it is a pass-fail indicator, and it integrates both the steam pressure achieved as well as the chemical and the temperature indicator. So this is a steam and temperature, and if it is pass, you accept it. If it is fail, you reject it, and it has to be there in every run of the autoclave. So every time you run an autoclave with a single load or multiple loads, this has to be done. The technician on opening the autoclave has to check it, stick it on your logbook, and sign it. So the load number and whether it has passed the integrating indicator is important. Type 6 indicators are biological indicators, and there are 2 different species for ETO and steam, and they are not interchangeable. So if you have a ETO BI, then it should be used in ETO only, and vice versa. So these contain spores with a self-culture mechanism. So once you run it, you have to break it, and it will remain inside, and if the color changes, then you know that it has worked or not worked. So how frequently a biological indicator should be used, that is also controversial. It varies from those who are very cautious will use it once a week. Those who are less cautious or have less load may use it once a month. So the idea is if you are using a integrating class 5 indicator, then the importance of biological indicators become reasonably less important, because you are doing integrating indicator at every run of the autoclave. So you are sure. So this is the reference document, and I will suggest anybody setting up OT protocols to go through these CDC guidelines. That it has been updated in 2019, just pre-COVID, and I think it will give you great insights into what I have summarized. Thank you.
Thank you very much, Dr. Bhaskar. Very nicely attended IC. I'm very thankful to all of you for attending it. If you have any questions, please, we can ask our speakers to come over and sit here, and you can shoot the questions. I think I'll answer your question because that was something that was left in a big query. See, the best way is that when you do a pre-operative checkup of the patient, ask him to consult his cardiologist or physician and take that person's consent on whether to stop the blood thinner or not. Because yes, no doubt that we have very minimal bleeding and we don't really need to stop blood thinners. But from a medico-legal point of view, you should be always ready on the better side of the law. That is, have everything clear. If the cardiologist says that you can stop it, or sometimes they ask you to replace it with heparin. So those patients who are on dialysis, they switch over to heparin. So then do that and follow the protocol. But it's best that you should have a clearance from a physician on either side, whether to continue or to discontinue the blood thinners. Yes.
Even if you're using xylocaine peri-block now, physicians write 20 years old sentence that please don't use adrenaline. They're still writing that please don't use adrenaline and take consent with due risk. That doesn't carry any meaning.
No, it doesn't.
Because they don't know anything, what is topical, what is peribulbar. So
very true.
So
but then you have to always err on the side of the law. And
because
you have to be clear on your side that you should not do something that will put you in trouble later on.
no, blood thinner should not be stopped because you require blood for the heart also. No, heart is more important than eye.
Exactly. So you have to ask the person, the cardiologist. Many patients have had a history of a cardiac event 10 years back. They don't even need a single thinner or maybe a single thinner like aspirin. So many times they are allowed to stop the medication without any fear and this thing. But if it's a recent event a year back and you have put a stent, you definitely don't want the blood thinners to stop.
That's right.
That decision has to be taken by the physician or the cardiologist who's looking after the patient. Leave some work for them also.
They always write, please stop blood thinner before surgery. But that is meant for the that is meant for the orthopedic surgery.
So, can we just have a show of hands as to how many people are routinely stopping blood thinners?
I don't stop.
So, a fair amount. And just as a corollary to this question, how many people are stopping prostaglandin analogs like latanoprost before surgery? Okay. So, these controversies will always be there. In this AIOS, there was a session in which it was told by an authority that you don't need to stop latanoprost and prostaglandin analogs. They do not cause CME in this sitting.
Right.
So these controversies will always be there. I think we can go to the next question.
Studies in the long run will let us know with a meta-analysis of the data as to what is the actual relevance of all these steps that we take. But till there are studies which state clearly that you can safely switch it off, I think you should follow the norm of keeping it if possible. And if you have to switch it off, ask the person concerned. And many times they ask you to take alternative medicine. Like I said, heparin. Heparin doesn't cause bleeding. So they replace it with heparin, and that's their field. We don't interfere in it. That is the best way to do it. Don't interfere in other people's field. Yes.
Other thing.
Yes.
Sizing of the OP.
Yes.
As per NABL guidelines,
Yes.
are there minimum size for IOP?
There is a minimum size. Actually, depends upon the number of tables you are using inside the OT. For one table, it should be at least 6 to 6.5 meters square, the minimum size. And the size of the entire OR complex should be at least 75 meters square.
Is that NABH?
No, I'm not sure regarding that.
No, NABH does not have any such, neither about the size of the OT, nor about the requirement of a air handling unit, right? Not about a modular or a steel OT. NABH does not have requirement. NABH, the only requirement is the humidity range and the temperature range is as specified, whichever way you attain it.
One thing is, you showed that instrument which is going into AC, you clean with the solution. You showed
use
in,
normal.
but there was only one bowl. So same thing, same solution you are using for irrigation and hydration.
I'm sorry, I didn't get you.
You are cleaning the tip of the instrument with the bowl which is containing the dingle lactate or solutions, whatever you are
Right,
using.
right.
But same solutions you are using for hydration after the surgery, or you have got different
No,
bowls?
it's kept separate.
But
It's
there
kept
was only
separate, and that was
one-
taken directly from the machine just before the surgery.
Because there was only one bowl on the
because
table.
you don't want any residual
That solution
material
should
like
not be used for
viscoelastic
even
and all
for
that going
irrigation.
to the side ports when you're
That
hydrating.
should not be used.
Absolutely not. Absolutely.
Absolutely. In our OT, actually, the solution which we use inside the eye is taken directly from the phaco
phaco.
tubings. And the
But
bowl
suppose
which we
sometimes
kept-
you're doing-
No, we don't draw that even for irrigating the surface of the eye, even we don't draw from the bowl. That is for cleaning up the instrument or dipping the instrument.
ETO. Formalin chamber is an absolute no-no.
Shouldn't be used.
Yeah. So, ETO.
Any other option?
If you have access to plasma.
Sir, what about the suture, new suture? There is double needle. So
ETO.
one needle we use and
ETO.
another needle,
It can be.
again ETO.
ETO.
See, gone are the days when we used to put it in a formalin chamber and leave it there, that we can use it, reuse it after 2-3 days, even weeks. Why it's also very important is that formalin tablets which you put out there, they many times get disintegrated and they kind of coat your sutures or any other material inside. And during my initial days of practice, I have come across a situation where there was a severe reaction in the eye when a viscoelastic which was stored inside a formalin chamber was used, right? So at this present moment where the culture of reuse is absolutely out and unacceptable, there is no philosophy of keeping an instrument in the formalin chamber to be used. It's just not right. You have to charge the patient if you want to for the suture, but please don't reuse it and risk your own work and practice. So I would not suggest it.
Another question, many people start sterilization of the ringer lactate and OVDs because they are already sterilized. So I really don't know whether we should be doing it again and again.
No, should not
Should
be done.
not be done because some people say you re-sterilize them and then
No.
But it should be observed for any.
that part we take care, but you don't have to sterilize them again.
So you
No,
know
because it actually
the
leads to sedimentation at times.
most common problem of improper irrigating solution and OVD is resulting in TAS, not end of as such. And the TAS was first reported in Alcon BSS in the US. So that's a paradox. So we have come a long way from that. So use good quality BSS, and if you have any incident, you should report it on the WhatsApp forums or report it to AIOS so that everybody knows that this particular company, this particular batch has a problem, and you can pull it out of your practice. That is the only thing that can save you. One thing we have not discussed in this IC is the water that you are going to use for autoclaving and cleaning of instruments, right? So that is another area of controversy. And I had worked in one OT in which there were 4 taps, and Pseudomonas aeruginosa would grow alternatively from one tap. So 1 month this would come clear, the next month it would grow, again it would be clear, again it would grow, and those were being used for instrument sterilization. And the problem of Pseudomonas aeruginosa is that it is easily killed by your autoclaving process. But the endotoxin that is there, so if there is a sizable load of Pseudomonas aeruginosa, even if you have killed everything, the endotoxin that is deposited on the instruments cannot be killed under 4,000 degrees Celsius. So they survive and they can cause TAS. So it is very important to have good quality water for cleaning the instruments and for running in the autoclave.
Preferably, if you are making a good OT setup, you should have a water deionizing unit
Or a RO unit.
attached to the main supply of water, because it's really very easy to use it for all purposes then.
How to clean water tank? Even the RO water has.
It is very difficult. In this same OT, to remove the aeruginosa problem, we had to change the entire pipeline. Even then it kept coming. It was a 9-story building. We were on the first floor and the tank was, and we changed the entire pipeline to see whether it would cure, but it was not getting cured. So it is there in the source.
So
I think we have to close our session.
I have a last question, sir.
Yes.
It's upon building up the OT chamber, like OR. I have seen at many peripheral centers, they use toughened glasses as the wall, or aluminum partition as the wall. Or is it important or necessary to tile up the OT, like doing the tiling of the wall?
I think
what should be done?
Answer that. That'll be, yeah.
Inside the OT, you are telling?
Yeah, like OR, if you are
No,
constructing the
OR has
OR.
to be, there has to be a brick wall covered with either panels which are made up of stainless steel or EGP, or tiles has to be used on top of that.
It should not be like
No,
like
no.
toughened glasses or the partition.
Only the
aluminum
partitions
partition.
can be made with those.
And what ma'am said, that the grouting should be very proper. If you find that there are areas of where the cement has broken through, they should be immediately repaired and properly sealed, because those are the crevices where a lot of bacteria grow, and your sterilization substances don't reach. So that becomes a source of your infection.
Thank you.
Yes, please.
Must be two entry for the operation theatre, or one entry is sufficient for NABH?
Operation theatre complex.
Ideally,
For the operation room, in the operation theatre.
operation theatre should have one entry, but
One for the patient and one for the doctor.
no, that is for the OR complex. That is like to come to the induction area, but operation theatre as such should have only one entry.
But the other thing which we have to take care of, the instrument coming in and going out should be different. The soiled instrument should go out through a different window panel, and the fresh instrument through a different one.
Scrub area must be before operation theatre, and we can make in the operation theatre.
No, outside the operation theatre.
Adjacent to the theatre.
Adjacent.
Inside the work complex, but outside the operating.
See, the operation theatre is divided into 4 zones. So this comes in the zone which is just before the complete sterile zone, right, Supriya?
Yes, and actually the scrub area, there will always be water, how much ever precaution you take. So you cannot have that inside your theatre. It has to be outside the theatre, but inside the OR complex, where your block room and other rooms are located.
Thank you so much for attending this IC on a Sunday morning, last day.
Sir, just one doubt,
Yeah,
sir.
please.
Yeah.
Like about the integrating indicators which you mentioned, how many to place in a bin and where should we place them?
It should be placed one in every run of the autoclave at the remotest corner. It's called, there is something called a towel challenge. So you wrap it in a towel like you would, multiple towels, and put it at the remotest corner. That is if you are,
In a bin we have lots of sets.
no, one outside the bin.
Yes, but this will be taken as
Yeah.
a separate area.
In the bin, process indicators
अलग ही
only.
बना सकते हैं। ये अंदर नहीं है ना, so कोई प्रॉब्लम। हाँ, वो कर सकते हैं।
Thank you so much for attending.
Thank you, sir. Thank you, everybody. I think the next session will start, so we'll have to vacate the hall. Thank you very much for all your cooperation and help.
The issue people will tell you that this has to be done continuously. Because the moment